oncologist, treating both localized prostate cancer. She has worked extensively at the Proton Center, so is well versed in that treatment, as well as now treating recurrences in distant sites. Before she starts, I just want to remind you to fill out questions. If you need question cards, if you need a card, raise your hand, because we want to get those back for the QA session that'll follow right after Dr. Zheng's talk. So thank you.
Good morning. So usually when we talk about radiation treatment of prostate cancer, we're talking about in the scenario of localized prostate cancer, meaning it's still in the prostate and, there are a multitude of options, including surgery and radiation for treating it. But radiation is starting to play more and more of a role in patients who have either a local recurrence of prostate cancer or distant metastasis as well. So I'm sure that some of you in the audience are very familiar with radiation, and some of you perhaps less so. So first, maybe I'll just start by reviewing what are the things that are available, what are the tools that are available to me as a radiation oncologist to be able to offer the kind of treatments that we're talking about. So most of the radiation treatments in the United States are given by what we call external beam radiation, meaning that the radiation is being generated outside of the human body using these machines called linear accelerators. So this is a linear accelerator, and this machine is actually generating the radiation. There's no radioactive material anywhere in the room, and it's only when this machine is on that the radiation beam comes out. So the radiation beam in reality is invisible, but this is a cartoon depiction of, this is the head of the linear accelerator called the gantry. The beam comes out, and it points at a portion of the patient's body that we're aiming it at. And this is what a CT slice might look like in the area of the prostate, so the beam comes out and kind of is hitting the prostate region. And so radiation therapy has evolved a lot over the past few decades. Our goal for both radiation and any other cancer treatment really is we want to kill cancer cells, and we'd like to kill not too many of the normal cells if at all possible. And so the historical way that we did the radiation treatment was we would take x-rays where you would see bones, and you would say the prostate is hereabouts, down low in the pelvis. This is a femur, this is another femur, so this is pretty low down the pelvis. We think the prostate is probably here somewhere. For this one, they actually put 3 little markers in the prostate itself to help guide it, and we draw these little shapes that say, okay, this area, we think if we cover this area, we're pretty sure we're covering the prostate. And so if you look at a CT scan kind of slice through the body at an area of the prostate, that's where this red outline is. We are definitely hitting the prostate with the beam, but you end up treating a fairly significant area around the prostate as well in order to make sure that you're covering the prostate. So as technology evolved, we started doing something called IMRT, intensity modulated radiation therapy. And what that means is instead of doing kind of rectangular blocked radiation fields, we have a lot of different beams that all come from different directions. They all converge on the prostate so that the red area, which is where the high radiation dose goes, is no longer a big kind of square box, but it's now actually trying to be shaped like the prostate itself so that we're causing less side effects. So this over here is kind of describing, again, this is an x-ray picture. This is the sacrum, this is the tailbone in the back. This yellow blob is the bladder. This brown blob is the rectum. And this kind of dark reddish blob is the prostate as well as the seminal vesicle. And then this kind of bluish area is a few millimeters around the prostate, trying to make sure that we're both covering the prostate as well as making sure we're covering any cancer cells that are trying to escape to the surrounding area. And so this is a lot of different beams of radiation coming in from different directions. You can kind of see that the pelvic bone, it looks like it's changing. We're rotating around a little bit to get this kind of tight radiation, high dose radiation around the prostate without over-treating the area around it. I get a lot of questions about something called stereotactic body radiosurgery, or SBRT for short. And basically, it's like a very advanced form of this intensity, IMRT, intensity modulated radiation, where you have a lot of different beams of radiation that are all coming from different directions, and we're just doing very focused treatment so that it's safe to give a very high dose of treatment and a radiation dose in a very few treatments. The traditional way that we give radiation to prostate cancer is given every day, Monday through Friday, for several weeks, whereas with something like SBRT, we give it usually over 5 treatments spread out over a couple of weeks. And so there are a lot of different radiation machines that can do this SBRT. CyberKnife is probably the most successful at advertising, so that's the one that most patients have heard about. I also hear a lot of questions about this thing called Gamma Knife. It's a very similar concept, but Gamma Knife is specifically for the brain, so it doesn't treat anywhere outside of the brain. And so these two pictures down here, this picture is what we just talked about in the previous slide, the IMRT, where you have the red, which is the prostate, and the yellow line kind of represents the full dose that we're trying to give, and the blue line represents about 75% of the radiation dose. And so you're trying to cover the red area with a yellow line. And the picture on the left here is what you might see if you were to do SBRT, which is, it's hard to tell because it's a subtle difference, but it is just a millimeter or two tighter around the red area compared to the IMRT. And believe it or not, because of where your prostate is situated, meaning it's touching the rectum and it's touching the bladder above and in front of it, by being just a couple millimeters tighter around the prostate, this actually makes it possible to give the radiation and safe to give the radiation over 5 treatments, rather than if you just covered a few millimeters more, you now have to slow down the radiation a bit to give your normal cells like your rectum and your bladder a chance to heal in between the radiation treatments. And so we also have access to a technology called proton radiation. And really, proton radiation, it's still radiation. The major difference, it's just that proton radiation goes into your body and stops after a certain distance, whereas regular radiation penetrates through the body. So again, kind of the standard treatment of IMRT, we have a lot of different beams that come from different directions. They converge on the prostate. It gets a high dose. With proton radiation, we just use 2 beams. It goes into the body, covers the prostate, stops. Same thing on the other side. Goes into the prostate, body, covers the prostate, and stops on the other side. And so if we're going to be evolving in terms of radiation therapy and treating a smaller and smaller area in order to cause less and less side effects, the other part of the technology that had to evolve was image guidance, meaning if you're going to only treat the prostate plus 1 to 2 millimeters, you better be pretty sure you know where the prostate is before you turn on that beam so that you're not missing it. And so again, in the good old days, we used to do a lot of just kind of X-ray based radiation treatments where, you see the bone, you don't see the prostate, but you kind of figure it's somewhere in here, so we're going to aim it. Whereas nowadays, on the, most of the treatment machines that we're doing, we can actually do a very low dose CT scan prior to turning on the radiation beam with the patient lying in the treatment position so that we can make sure we see the prostate, we aim it at the prostate within a millimeter or two, so that we can be sure that we are being very tight with the radiation, but still hitting the area that we need to. The other kind of major tool that we have in the field of radiation oncology is brachytherapy, which probably some of you are quite familiar with as well. And what you do with brachytherapy is the radiation is no longer coming from outside of your body, but we are actually putting something radioactive into your body. The more traditional way of doing this is something called low dose rate in contrast to high dose rate that we'll review next. But what happens is this is a kind of a cartoon of a picture of what a patient would look like lying on the table. And so you have the penis, the testicle, you have the bladder here, the prostate is over here, and the rectum is over here, and there's an ultrasound probe that goes in, and there's this template that we push up against the body, and it kind of looks like a battleship template, so, like A through, D, 1 through 9. And, we do an ultrasound before you come for the brachytherapy so that we map out the prostate and say, okay, we need to put a radioactive seed in, A3, A5, D9. And so you see this needle here, and that's actually what we do. We insert the needle on the template, and we kind of leave little radioactive seeds all along the prostate, and we have little kind of different positions. So this is what an X-ray might look like after brachytherapy. So you don't see, there's a femur over here, there's a femur over here, so this is pretty low in the pelvis, and usually it's somewhere between 80 to 120 of these little radioactive seeds that we put in to cover kind of the shape of the prostate itself. In the more recent years, there's been kind of more excitement about doing something called high dose rate brachytherapy. It's not felt to be any more effective in terms of treating the cancer, but what happens is, so you get the similar cartoon picture, but instead of having just one needle that your radiation oncologist is moving kind of through the prostate, they put in multiple needles at once. And what happens is, again, a computer calculates, we need this much radiation over here and this much radiation over here in order to adequately cover the whole prostate. And what happens is, instead of using a low dose rate source, they're using a spot of radioactive seed that gives a very high dose of radiation very quickly. So instead of being permanent, like with a low dose rate where it goes into your body and stays with you forever, this radioactive source only stays in the body for a few seconds. And we connect all these catheters to this robot. So the very radioactive source is in here, and the robot actually shoots that radioactive source out through these kind of catheters. It goes into your body, and the robot actually controls it, because we pre-calculated the seed will stay 10 seconds over here, 8 seconds over here, 20 seconds over here, and then shoot back in, shoot out through another catheter, go into the second needle, and kind of we calculate what the dwell time is in each one of these spots, so that you don't walk around with some radioactive source permanently in you. And so, in the era of kind of metastatic prostate cancer, that's kind of all treating the prostate. What can we do for cancer that spread outside of the prostate? For a long time, one thing that we do very commonly is when it spreads to the bone, sometimes it will cause pain. It will cause compression against nerves, which can cause pain or weakness. And so we want to use radiation to help with that particular problem. Again, the traditional way we do that radiation treatment is kind of with rectangular block-shaped fields. So this is a slice of a CT scan through the chest. This is the heart. These two black areas are the lungs. This is the sternum in the front. These are the ribs on the side. And this is a vertebral body in the back. And there's some cancer that's in this vertebral body. And so what we do is we shoot a rectangular kind of square block-shaped radiation beam front to back, so that we're hopefully killing off the cancer cells that are in this vertebral body. With this stereotactic body radiation, what we do is we use different beams that come from a lot of different directions, so that now the radiation dose is more conformed around the area that we're trying to treat and doing less collateral damage. Similarly, one area that we sometimes run into is we do sometimes in radiation treatment prophylactically give radiation to both the lymph nodes in the pelvis as well as the prostate when we're treating for curative intent purposes, but sometimes it doesn't work, and the cancer comes back, and say this is kind of a image through the abdomen. So this is a vertebral body in the back, that's a kidney, these are bowel, this patient probably drank some contrast, so that's why their bowel is white. But there's some cancer that's come back in some lymph nodes. And so we are using SBRT to give very focused radiation just to the lymph nodes where the cancer came back, instead of trying to treat a big area. And this is sometimes safe to do even if you've previously had radiation to the lymph nodes before. And so I think, Dr. Lin was touching on this as well, which is with any kind of cancer therapy we're giving, the goal is always that the perceived benefit of the treatment should outweigh what we perceive to be the side effects of treatment. So what we're proposing to do to you should hopefully help you more than the side effects of what we're proposing to do. So we kind of been talking about how do we minimize side effects, meaning, we looked at all these advanced imaging techniques so that we can better pinpoint where's the cancer, so that we only treat a small area. We've been talking about all these kind of advanced technologies so that we can be better at, let's just focus the radiation on that particular area. And then Dr. Lin was starting to touch on, how do we maximize benefit, meaning, how do we choose the patients that it's going to help the most. With radiation, certainly if there's a particular spot of tumor that's causing a problem, meaning pain, nerve compression, we can use radiation to help fix that particular problem. Or we can try to use radiation to do this debulking the cancer to prolong disease control, meaning I don't think I'm treating 100% of the cancer and I'm not going to cure you, but can I treat 99% of the cancer, and is that going to help, keep the cancer controlled for a longer period of time? So, for example, this particular study that came out of Europe, they looked at over 100 patients who previously had either surgery or radiation for what they hoped was curative treatment for their cancer, but it turns out that at some point their PSA started going up again, and they ended up developing metastatic disease. But they developed less than 3 sites of metastatic disease, and they aggressively went after all 3 of those sites with this high-dose radiation. These patients did not have hormone therapy prior to developing metastatic disease. They were staged with kind of newer scans than just a bone scan and a CT scan. And most of these patients had, when they presented, just had 1 spot of metastatic site. So it's a fairly low burden, this oligometastatic setting. And what they found was that radiation is pretty good at treating the area that we're treating, which is good. But more importantly, this is a graph of time versus how long did these patients remain disease-free after the treatment. And, these are patients who have metastatic cancer, so most of the time the cancer will spread and you will see it in other spots. But there are some patients at about 3 years, about a third of the patients, their cancer has not spread yet. And about 5 years, about 15% of the patients, they didn't have a new spot. So meaning that, we still think that at some point the cancer is going to show up in a different spot, but at least with the radiation, maybe we buy you a little bit more time off of needing additional treatments. And so these are a couple of studies that are trying, not yet sophisticated enough to do genomic data, but simple factors like PSA doubling time, looking at how do we choose the right patients who would benefit from this, because the goal of this is not to treat everything we see and then 3 months later have new spots show up. The goal of this is to treat everything we see and give you more time without spots showing up. So for example, this is a study looking at 50 patients. They had up to 3 sites of metastasis that were treated with just radiation alone. And, on average, the whole group of patients had about 2 years before they developed more sites and needed to start hormone therapy, androgen deprivation therapy. And they were looking at, a short PSA doubling time seems to be helpful in terms of differentiating between patients who are more likely to get a longer period without treatment versus needing treatment, more treatments anyway. And this is another study of 66 patients looking at if you had a lower PSA, fewer number of metastases at the time of doing the radiation, it was more likely that the radiation was actually helpful. So as a radiation oncologist, I think we're getting better and better at taking care of the spot that we're aiming at, but we're also trying to evolve and see, can we be helpful in terms of treating patients who also have cancer that's spread outside the prostate. And one very active area of research is trying to use radiation as almost a vaccine. So to help the immune system, to boost the immune response to your cancer. And that's kind of in this current era of immunotherapy. So for example, if you have a cancer cell and we're aiming the radiation beam at it, lightning bolts, radiation oncologists like using lightning bolts to describe radiation. And, hopefully, yes, we're pretty good at killing that cancer cell, but what we're hoping is that we're inducing some kind of inflammatory response locally so that immune cells will come in and take up chunks of this now dead cancer cell and carry it to your lymph nodes to help propagate a systemic immune response so that your immune system will now kick out these immune cells that are specific for the cancer so that they can hopefully circulate around your body and not so much the cancer that we already treated because we took care of that one, but can circulate and take care of other spots as well. And so a lot of the excitement for this, there's been we have not progressed as much with immunotherapy in the world of prostate cancer as they have for other kinds of cancers out there, for example, melanoma. So this is kind of a study that came out several years ago now. And for a patient with melanoma, that kind of really got a lot of excitement going with radiation trying to induce this abscopal effect, meaning we're not so much that we're helping treat the tumor that we're aiming at, but that we're helping to treat cancers that we're not aiming at. And it's a patient who had metastatic melanoma, so they had, multiple spots of disease. This is a spot near the spine in the back. This is some lymph nodes in the chest. This is a spot in the liver. There are some spots in the spleen. And they initially started on treatment with this checkpoint inhibitor immunotherapy agent, and it was working for a while. So at first, it kept their cancer at bay. And then, unfortunately, they started to progress, and tumors kind of started to get larger. And there was one particular spot near the spine that was causing quite a bit of pain. So what they did was they gave that SBRT to that particular tumor. And not surprisingly, as time went on, that particular tumor shrank. That's what we expect to see. But shockingly, they saw that actually the other spots of cancer in the body, the spot in the liver, the spots in the spleen, those shrank as well, even though the drug was not working anymore by itself. And so we are studying that in our system as well. We're shortly going to open a clinical trial where we look at patients who are, newly diagnosed with metastatic prostate cancer. They're getting androgen deprivation therapy and abiraterone. And we are randomizing 2 arms, one arm where you just get the standard of care therapy versus another arm where we give a spot of radiation to a particular site of metastasis. And we do blood draws to try to measure, are we able to induce a different immune response with radiation plus hormone therapy versus hormone therapy by itself. So I think with that, sometimes for my own ego, I like to plug that for radiation oncology, it's not just about having the technology, but it's about how to use the technology that you have. So thank you.
Yeah. Wonderful. So I invite the speakers from this session to come on down and start taking questions. Please write your questions on the card, pass them to the end so we can bring them down here. I'll start with the first question to Dr. Lin. Dr. Lin.